Welcome to the fourth episode of our iSense Q&A series. I am Erin Manning, the Communications Officer for iSense, an EPSRC-funded interdisciplinary research collaboration. Our researchers are working to develop tools and technologies to track, test, and treat infectious diseases. This Q&A series is a chance to speak to and learn from experts working in fields related to infectious disease surveillance, testing, treatment, and beyond. Today we are speaking to Dame Anne Johnson and Professor Deenan Pillay from University College London and Professor David Heymann from the London School of Hygiene and Tropical Medicine on the topic Our Environment and the Spread of COVID-19.
Yes, thanks, Erin. I'm David Heymann, and I'm a professor of infectious disease epidemiology at the London School of Hygiene and Tropical Medicine.
Great, Deenan.
Hi, everyone. Deenan Pillay. I'm Professor of Virology at UCL, also Vice Provost International, and I've been involved in various discussions around COVID, both diagnostics and drugs, and more latterly vaccines.
Thanks, Deenan. Anne, would you like to introduce yourself?
Hi, I'm Anne Johnson. I'm Professor of Epidemiology at UCL and also incoming President of the Academy of Medical Sciences. And I've been working in areas such as hospital-acquired infection on the DELV Committee with the Royal Society, test and trace, and other aspects of a viral spread, including through being part of the Virus Watch project at UCL.
Great. Thank you all so much for joining us. I just want to note that Deenan and Anne have to leave at 2, but David's going to stay with us till 2:15. Okay, so I'll just get into the first question, more of an overarching question. So in the last 10 months of restrictions here in the UK, and with London going into Tier 3 as of yesterday, or today actually, what has been the key observation over this time regarding the global response to COVID-19 for you? Maybe Deenan, would you like to start?
Wow. So some broad perspectives from my sense, both in the UK, but then I'll be quick, and then international. And I think within the UK, what I think has been surprising to many, although not necessarily surprising, is the degree to which there has been an acceptance of social distancing, limitations of freedoms and so forth by the population, and clearly the most effective impact there has been in the UK on the UK pandemic was the first lockdown in March. It had a very positive impact, albeit testing and so forth was much less than now, so it was more difficult to assess precisely how things were going, but certainly in terms of hospitalizations, I think that was clear. So something about behavior of people. Of course, over time, that has been, I think, diminished. And I'm continually informed by my social science and behavioral science colleagues that this is not about people becoming tired of those restrictions and fatigued, but rather it has been the more confusing messaging that has come out. So clearly, something about engagement of the population with the state is important. And of course, the third thing that we see in the UK is about the diminution of a public health infrastructure over many years, that are particularly more recently, which has meant that many of what we would say would be our normal response in terms of public health engagement with people, testing, contact tracing, has been inadequate for those reasons. But if we briefly look across the world, it's really interesting is that it's quite unpredictable on the face of it why certain areas of the world have done well. If we put to one side about physical demographic differences and climate differences, clearly there are those determinants of infection. But really, it seems the key things are public trust in the state and those who are advising them. And if we look even in Europe, where the success of countries like Greece, or in Asia, Vietnam, which say something about, it's not just about the wealth of the society, it's about trust. And the second thing is, of course, the infrastructure, and in the Far East, of course, an infrastructure that was built on the back of SARS, and which has enabled there to be a reintroduction of some of those constraints, social constraints that have worked very well compared to other parts of the world. I'll stop there, and it'd be interesting to hear Anne and David.
Great, thanks very much for that, Dean. And Anne, would you like to add anything to that?
Well, I mean, I very much agree with what Deenan said. I mean, I think the other interesting thing for me has been that a lot of the countries, I think that the countries in the Western Pacific are really interesting because they intervened early. They had different epidemics, but they were able to introduce, controls that were long lasting with clear messaging, and that speaks to what Deenan said, as well as closing their borders. And so we had a very different epidemic actually, but we also had a different response. And I think it's important to understand that. I do remain struck, having been around for the AIDS epidemic, how incredibly reliant actually this is on behavioural science, and how, at least at this stage in the epidemic, and how that tends not to be the sort of necessarily the top priority, and we always have to think about that at the beginning of an epidemic. I'm also actually knocked out by how amazing the vaccine response has been, and I hope these vaccines will prove to be as effective as some of the early trials show. But as ever, this will all be about the rollout of the vaccines. But nevertheless, I mean, I think we have to pay tribute to some of the scientific effort which has really got those vaccines out into the field in record time. But we're going to have to watch, as ever. I think one of the things that's been problematic is that, rather than emphasising, as Deenan said, look, we have to get on top of these clear messages and stay with them until we have some other solution. The danger is to be constantly promising a technological solution, which in the end has a very important part to play, and that's true of test and trace, and thank goodness we've got the testing, but it's actually the implementation and the systems science, which I don't think we've seen enough of, to make these systems work. And you've seen how difficult it is. I mean, countries like Germany, who apparently did very well, or Czechia in the first round, are now facing very similar problems, and have not really been able in the end to maintain all those systems to keep things under control. So moving forward, I hope we can somehow learn those lessons and not go into another boom and bust with this virus, and save our resources and our energy to get these vaccines out as fast as possible, but to continue the research to know how long their impact's going to be. And there we've got to rely on a real combination of good epidemiological, virological, and immunological research alongside the delivery science, both nationally and globally.
Yeah, of course. Thanks very much. And David, do you have anything to add to those two?
Yeah, thanks, Erin. Yeah, I've been in a privileged position because I've been chairing a technical advisory group to WHO, to the emergencies program on this COVID. And yesterday, we actually had our 58th meeting since the 10th of January. So we've had an opportunity to talk with many different countries around the world who come into these meetings. And I just follow on what Deenan and Anne said. Asia has done quite an impressive job in dealing with this outbreak after SARS, after MERS coronaviruses did such damage to their economies and their public. But in addition, it was interesting. Our group first met on the 10th of January after WHO had on the 5th of January released information about this outbreak. And by the 20th of January, the countries in Asia, including Vietnam and Singapore, had already begun to identify cases and were responding to this as outbreaks. And what they learned early on was that this wasn't like flu. This entered a country in outbreaks, and then it spread into communities. So they started very early, as did Germany, to do contact tracing and identify the people who needed to be isolated, and did quite a good job on doing that. But as Deenan said, they also have a population which is very solidarity, as has been in the UK, and willing to work together to protect others and protect themselves. South Korea yesterday announced that they had now lost control in some areas. They actually only had 1,000, just over 1,000 new infections to report. But for them, that was a major issue because they've been able to keep it very low. And I'd come to what Anne said about Germany also. Yeah, Germany started out very well, and now they're seeing that they also have difficulties. But they're not bluntly shutting down economies, and Asia never did this. What they did was what the UK is now doing, shut down places where transmission occurred and giving the compensation to them rather than bluntly shutting down an economy for everyone.
Yeah, of course. Thanks very much for that, David. Sticking to the topic of behavior and behavioral changes, and you talked about the rollout of the vaccine and the positive response to it. With the rollout, there is some fear that maybe some of the non-pharmaceutical interventions, such as social distancing, might start to relax a little bit. What are the factors that we needed to consider to come out of COVID-19 safely? I guess particularly concentrating around this Christmas period as well, to keep people safe during this time. Anne, would you like to start?
Okay, so, it's very interesting how this will play out. And you can hear now the messaging very clearly that the vaccine could result in people saying, oh, well, we've got a solution. And that, of course, was to some extent the solution that was test and trace was suggested as that solution. Of course, test and trace is just a tool that what actually test and trace works because people self-isolate, not because of the test. And it's with the fact that people self-isolate mainly and get tested before they get tested that reduces transmission. But the vaccine should, or I hope could be, an incentive for people to recognise that, difficult as it is to lose all these freedoms, it's the worst time to go and catch it when you've got a vaccine that could save you from infection and from the severe impacts infection if you can just hold on for a few months more and we get this rolled out at least to the most vulnerable people in the population. And that is actually becoming, I think, the dominant message, which is now coming both from scientists and government, that this Christmas period and the holidays is a real risk simply because you're getting more contact between people. On the other hand, the social kind of pain of not being able to meet with people is really difficult. So I hope that this message will be heeded. If people now actually, if they are going to mix, need to be really careful before Christmas. That's why I think coming out of lockdown at the beginning of December, particularly difficult, because now we're seeing 2 weeks later increased transmission. So people really need to be particularly careful in this run up to Christmas, so that when they do start mixing again in December, they've got the high, A, they should do that very cautiously, and B, they need to go into it with the lowest possible risk of taking any infection to their families. And I think the vaccine is quite an incentive to maintain that. I don't know what Deenan and David feel.
David, do you have anything to add to that? Thank you very much, Anne.
I think in looking at the outbreak in general, governments have created a framework within which people can work. They've set up some policies and they've forced some social distancing or physical distancing. But in the end, it's down to individuals, as Anne said. Individuals have to be able to have the knowledge to do their own risk assessment. And especially before Christmas, they have to know that if a young person went off to a Christmas party or a pub or somewhere where they could have been infected, they could take an infection home to their elderly parents or their elderly grandparents. And so what's needed going forward with the vaccine is understanding that it isn't the all solution, that they need to continue to do a risk assessment before they make any exposure possibilities to people who might be more vulnerable. At the same time, once we understand clearly whether vaccines are only preventing serious illness or whether they're also preventing infection, then there can be a whole new strategy developed, and maybe even the target groups will change. Right now, the goal of governments in Europe is to decrease deaths and decrease the burden on hospitals. If there's a vaccine that does actually prevent transmission for a long period of time, then they can talk about decreasing transmission in the community. But until that, they're going to focus, I believe, on decreasing deaths with the vaccines that we have and making sure that that burden on hospitals doesn't increase.
Yeah.
So transparency is going to be important. Governments are going to need to tell people what's going on, who's getting side effects, what they are, and maybe a weekly report saying, here's the impact of the vaccine this week. Will encourage people to be vaccinated. But Deenan may have other ideas also.
No, briefly, I did all very, very sensible and insightful suggestions. The only thing I would add is understanding about individual responsibility, which of course is within us all, is dependent to some extent on scientific literacy at a basic level, and the expression of that scientific literacy from above. And what has struck me within the UK is the converse, is just how scientifically illiterate our leaders are. Angela Merkel was I remember, gave a very coherent talk about R and the epidemiological determinants of spread, and she could do that, and because she, I think, started life as a physicist and so on. But it is really striking that within the UK, scientists, our science leaders have not really had the opportunity to speak to the public themselves. It has had to be distilled through a political prism, which of course itself has been characterized by hyperbole, the magic bullet of whatever it is at whatever time. And I don't think that has helped develop a population-based understanding of this infection, which of course is required for us to take personal responsibility. So I think it is to do with leadership as well.
Of course, thanks so much, Deenan. Sticking on the topic of communication, Andrew Hayward has asked, how do we get the messaging on vaccinations right, particularly in groups like BAME communities and poorer communities where the recent evidence shows uptake will be low? Deenan, maybe you'd like to start on this one.
I'm not the best person to, but all I would say is that we have got to distinguish between the anti-vaxxers, and actually a far bigger group of people who have legitimate concerns here, because these vaccines have been developed very, very quickly. It's not helped, of course, that some of the vaccines, for the AZ Oxford vaccine has had these sort of errors in the trials, which of course have been, that these messages amplify uncertainty. And so there needs to be real transparency. I agree with David, transparency about how these risk benefits are expressed in order to and the message, of course, is that yes, while there are potential problems with vaccines, the alternative of being infected with COVID is far worse. And that is often missed when we're talking about trying to roll this out. And lastly, we do need to target our messaging to the different communities that are needed, particularly the communities you mentioned. Andrew mentions poorer communities who are themselves at much higher risk of getting morbidity and mortality.
The only thing I'd add to that, Erin, is that in the Academy of Medical Sciences report on preparing for a challenging winter, one of our first recommendations was that there should be much clearer public health campaigns which are co-produced with the public and with the affected communities. So I'm very struck that we hear a lot of expert view, but we don't hear, there hasn't been that much work that I've seen directly discussing with the public how we should develop these messages, and particularly working with community leaders in developing messages for particular communities in the right languages and so on. But so I think though that sort of public engagement is very interesting. We did work with the public to some extent in the Academy report, although quite briefly, and some of their messages were fascinating in relation to views about, first of all, making choices and assessing risk, but also of engaging in this messaging in ways that people could understand. And I haven't seen a lot in the literature on that.
Great, thanks very much, Anne. David, do you have anything to add to that?
Yeah, just one thing, the messaging, once the messaging is there, as Anne said, then it's going to really need some champions. And those are people who come from those communities, who are well known, who are trusted, and who are using those messages as they motivate the people to get vaccinated. And you can't replace that plus the transparency of the government in telling people what to expect and what not to expect from a vaccine.
Yeah. So very clear messaging and at a community level. My next question is, we've talked a lot about behavioural factors that have affected the response to the pandemic. I wanted to talk about any particular environmental factors that you think have contributed to higher rates and rapid spread of COVID-19 in the UK, and if so, what needs to change for future outbreaks and pandemics. Maybe Anne, would you like to start?
Yeah, well, my personal concern is that people don't understand how to mitigate the risk of transmission in households. And when we saw in the first wave, I couldn't understand why you're seeing this sort of continued amount of transmission that went on for quite a long time before we reached the peak. And I think some of that does reflect that we stopped mixing transmission between households during lockdown, but not within households. And I think a lot of people, and they still say this to me, they assume that if they're in a household, there is nothing they can do to stop transmission. And yet we know that's the highest risk environment. You've got long exposure to people, it's an enclosed environment, you're indoors. Now, I realise there are all sorts of social inequality issues here, because some people have got more space than others, and clearly if you're in a house with a lot of people in it, and particularly with little kids in it, it's very difficult to, socially distance within a household. But that said, in households where people have got their own bedroom and things, it's really important that they can stay there and have their meals there and be isolated from the rest of the house. Difficult that is. So you have high levels of hygiene. You can also introduce mask wearing and so on within a household, maintaining ventilation. The BBC did some excellent pieces on how to do this in a household when the very first cases arise, and yet we don't see those messages again. Was it Fergus Walsh who's so good at this? And he did these great demonstrations that we could really do with him doing that again to demonstrate to people how to stop transmission within a household. This is going to be a really important route over Christmas. And I've certainly been asked a lot to try and help people think about ways they can get together at Christmas, but minimise that risk of intra-household transmission by high levels of hygiene. Anybody who's sick, trying to self-isolate within that house, or not going, obviously, to Christmas with their family if they feel at all sick. And all those messages, I think, are not emphasised enough. A very high proportion of infection is occurring in these environments.
Yeah, thank you, Anne. David, maybe do you have anything to add to that?
I don't have anything to add. I think Anne gave a fairly complete answer. What I would say, though, is that regarding the environment, I think we've also seen what can happen when cars stop polluting the environment, and when a whole series of things happens, it makes life much more pleasant for us, as well as, in addition, giving us a better chance at good health. So I think Andy Haynes at the London School and I have been talking, I think we wrote an article a while back about these changes, and hopefully they will be something that convinces our policymakers that there are things to do. I know right now I'm in Geneva, and in Geneva it's impossible to drive in the city because they built new bicycle trails during the shutdown with COVID, and they're going to leave them up. And that will decrease traffic in the city because they have adequate public transportation for people to use. So I think government has to nudge a little bit in taking advantage of what we've seen now can be happening today without an electric economy, and really move ahead with that. Although many people don't agree with that in London and in various cities as well.
Yeah, I have seen a couple of extra cycle paths pop up in London that people aren't happy about. Deenan, would you like to add anything?
Finally, that following on from particularly Anne's comment about household transmission, is, and Andrew Hayward has spoken a lot about this as well, is that the fault line, COVID has uncovered the fault lines in society that determine, health, and identified the inequalities which underpin health, and again, right from the beginning, the initial messaging that came out from government was just assuming that everyone was like them. Everyone is like us, as talking about, well, you need to work from home and so forth, without recognizing really these huge schisms within society of the multi-generational households, people sharing rooms, people, of course, not being able to afford to not work, the gig economy, all of those things, which is why the infection did hit those people, and without recognizing that you can't just ask people to behave in a certain way if you don't really have an understanding of their lives, how to incentivize isolation. I mean, I thought, yes, people talk about paying now. There's finally some payment, albeit not very much, minimum wage for people asked to isolate. But in fact, there should be incentives for people to change their behaviors if that's going to limit the transmission. And I think this is the broader public health. It's where public health, economic policy do come together, and of course that is critical to how we can respond to the pandemic.
So I just say it would be remiss not to mention the critical environment in all this, which is health and social care. So there's been an awful lot of transmission in hospitals, and to patients, to staff, between patients, and in every direction. And then, of course, the risk of going on in the community, as well as people being discharged into care homes with infections that was undetected, setting off outbreaks there. So I think there's a great deal that needs to be thought about the design of hospitals and sort of the training of staff in every walk of life in a hospital, from to doctors, nurses, porters, cleaners, catering staff, that everybody to remember that transmission they need to be protected with PPE, but they also need just as clear messaging about preventing transmission between staff and in social environments in hospitals, at the nurses' station, in sisters' office, all those places that can result in transmission, in canteens and so on. And it does worry me that we're now seeing once again rising rates of transmission within hospitals, which requires a whole raft of areas for design of the hospital environment and staff training.
Yeah.
Just that a bit, the countries in Asia did learn from SARS. And if you go to a place like Singapore, they have 200 beds in one hospital dedicated to isolation, with ventilators and renal dialysis units in each room. And they're ready for in the long term. That's just one hospital. And, being prepared, as Anne said, is very important in the future. And that talks about redesign and making sure that health systems are resilient.
Yeah.
And not shut down to other people when people with the infection are admitted.
Yeah, great. Thank you all for that. I realize it's just gone to, and Anne and Deenan need to leave. I don't know if there's anything you want to add before you go.
I would just, sorry for having to leave. I'm looking in the chat and about the mutations. In fact, I'm going on to the meeting, which is discussing all these variants that are being generated in the UK, and just to say that we on virus variants, we know already that there's, within individuals who are treated with monoclonal antibodies and convalescent sera, that viruses are emerging that are resistant to that. We know that some of those viruses are currently, as of yesterday, There's a lot of chat about some of these viruses not being detected by some of our PCR or even serology assays, antigen detection assays, for instance. So whilst there's no evidence that vaccines are being compromised, because vaccines elicit a large array of antibodies against many epitopes, clearly this is a moving target. We've always assumed that the viruses, the coronaviruses don't vary very much, and I suspect they won't at a population level. But when so many interventions are now being developed, both drugs and monoclonal antibodies and so forth, then of course those are the circumstances in which you may generate variants. The question is where they'll be as transmissible, or whether things revert back to the norm. But anyway, just a comment about that question in the chat. But sorry for having to leave, but thank you very much, and thank you. Great to see you, David and Anne and everyone else.
Likewise, and sorry to have to
Thanks,
go.
Deenan.
Not at all. Thank you both for joining us.
Bye-bye.
Thanks, Anne. Great. Thanks for staying on and chatting to us, David.
Sure.
Do you have anything more to add to what Deenan was saying about what should we do about the response and strategy to new threats?
Well, I think it's really important to understand that there's a world besides the UK. And what's happening in UK is happening in countries around the world. This virus is out of the box. It's everywhere. And it mutates at different rates in different parts of the world based on density of population, based on the number of transmissions that are occurring. So really, you can't gauge what's going on in one country to what's going on in the world. And that's part of the concern, is that should in one place a strain develop which is easier to transmit and is more fit than a virus in another country, will that virus then end up taking over and forcing out other virus strains in countries around the world? So it's very important, as Deenan said, I believe he said, to not only watch what the virus is doing as far as mutations, but to watch also what it's doing epidemiologically. And that's very important. And it's very important to also watch what it does to effectiveness of vaccines and therapeutics. So a lot on the plate of epidemiologists and virologists going forward.
Yeah, of course. Staying on that topic, I was going to ask a question about vaccine efficacy in relation to the mutations we've recently seen, for example, in Denmark with the culling of minks that were infected by COVID-19. But instead, I wanted to ask, what should the global community do to minimize the viruses crossing the species barrier?
Yeah, it's a very difficult issue. And one thing you could be thinking about is vaccines for animals. We're in a One Health world today where we have to think about both the animal and the human community. And maybe instead of sacrificing minks, they should try to develop a vaccine for animals that would protect against infection. It's very important that people start thinking not just of humans. MERS coronavirus is a good example. MERS is carried by camels, as everybody knows, in their nasal passage. MERS coronavirus is present with camels on a day-to-day basis. People occasionally get infected. And when they get infected, there can be transmission in hospital settings from poor infection prevention and control, and in households. It doesn't spread easily in the community. But the solution to that is not a vaccine for humans. It's a vaccine for camels, and make sure that the camels are vaccinated so they're not passing infection on to humans, which could at some point mutate in humans and become more severe. So in thinking of vaccines, we have to think of both the animal and the human communities. And the mink is especially important, as is influenza, because both of those are viruses which pass not only from animals to humans, but then back again to animals. And they go back and forth and back and forth. And during that period of time, they can cause mutations that do, in fact, cause disruption in the use of a vaccine, as occurs in influenza over a period of time. But it's not clear that coronavirus will be the same model. Hopefully it won't be.
Yeah. Are there any particular environmental changes that maybe need to happen to stop the virus jumping species barrier?
Yeah, the virus continues to jump species barrier because our population in humans is increasing, and they're increasing demand for animals, either for food or for pets or whatever. And that increase causes great densities of populations of both humans and animals, many times in close proximity, facilitating that breaching of the barrier by a pathogen or a virus or bacterium from an animal to a human. So we need to learn how to do a better job with our animal and agriculture. And at the same time, we need to take the environmental measures we can to make sure that those species jumps don't occur in the future. And that includes at wet markets in Asia, at live animal markets in Africa, and at a whole series of places where there is that possibility of a breach in the species barrier.
DeLuca has a question here. Is there a concern over the minks that have been buried in Denmark? May they have contaminated groundwater? And is there an environmental risk in burying COVID-infected bodies?
Well, that's the concern, isn't it? That there might be a contamination of the water table. And what's very important in all countries is to begin to do some types of environmental surveillance. For polio eradication, countries that are concerned about polio continue to look in the sewage system to find polio viruses, to see if that virus is circulating in their area. And the same can be done with COVID. You can do environmental surveillance. You can examine water supplies or places where you think there might have been a contamination and just determine whether or not that's occurred by taking a specimen of water, for example, and then doing a PCR and a concentrate of that water.
Yeah. Thank you. There has been a lot of research going on at LSHTM on developing standardized way of detecting COVID in wastewater. What is the benefit of this?
Well, that benefit is many-fold, and it'll be even more important as vaccines are developed, especially if those vaccines can stop transmission and interrupt people from getting infected. If that's the case, then you might at some point reach a state where there is actually herd immunity instead of just experts who don't understand it talking about it. Herd immunity can occur if there's solid protection against the virus for a long period of time. If that should occur, then monitoring the sewerage would be very important to see when people are excreting virus. If it all of a sudden increases, that might indicate there is an outbreak of asymptomatic infection somewhere. So these are very important things to be developing along the way.
Yeah, great. Thanks, David. I guess the approach is only a small part of surveillance, though. What does it mean for test and trace, and how should it fit into community surveillance and messaging?
Well, first thing, it's important to understand that this doesn't act like flu, and the modelers early on thought it might, and so their models misled many people because they were using parameters for influenza. In fact, this disease, when it enters a new area in a country or when it enters a country, stops off first in an outbreak. And that outbreak can be contained, as has been shown in countries even as poorly equipped as Vietnam. You can contain those outbreaks. You can do appropriate contact tracing forward, identifying contacts and getting them isolated so community transmission decreases. And you can trace backwards to see where transmission occurred and hopefully shut down that transmission. Japan early on knew that it was occurring in nightclubs, and they shut the nightclubs down and decreased transmission. They opened them up again then, transmission increased, they closed them down. But instead of these blunt shutdowns of economies, they just surgically cut down where they knew transmission was occurring from good epidemiology. And that's what's been lacking in many countries. The UK started beautifully doing contact tracing, all these other issues, but all of a sudden they felt this threat on the hospital system, and the only way they could determine to deal with this was to have a blunt shutdown of the economy to suppress transmission. And unfortunately, they also stopped the track and trace systems at the same time. Now trying to begin it again, it's important that it begins from the community rather than from the central level, because communities are where people have trust in contact tracers, and they work with them as they do for TB or for sexually transmitted infections. So it's wrong to say we can do contact tracing by track and trace from the center, and we can call up a person and they can agree to it. It doesn't work that way. It's face-to-face confidence.
Yeah, communication is definitely a key.
Absolutely, Erin, as you know. Yeah.
I have another question here for Andrew Hayward. That it is, what is being done to bring scientists together to learn from each other internationally? There seems to have been less of this than one might have hoped.
Well, Andrew, as you remember early on, I think it was in February, WHO called together about 300 researchers from around the world in person, actually, in that point of time. And then later on, they've been dealing with that virtually. And I think about 2 months ago, they had another collection of people together to talk about gaps in research. And WHO publishes those gaps. I think the UK's been extremely, as you know, Andrew, because you've been involved also, has been extremely generous in resources provided for research, either in the short term or in the long term on COVID. And that's extremely important that continue, that resources continue to be made available for the cohort research now that's necessary to determine things such as the length of COVID, long-term COVID, and a whole series of other things. Maybe, in fact, Andrew would like to say something because he's been heavily involved in this, Erin.
Yeah, I mean, I think the research response has been impressive, and maybe I suppose maybe I'm speaking just from personal experience, but I don't really feel as though I've had a forum to speak to other epidemiologists, for example, who are doing similar studies. So there may be more communication in other areas of science, and maybe that's my fault or the fault of the epidemiological community. But I do think there's a big issue now as to, a lot of these projects were set up in in an emergency with the aim of producing results that can inform this first wave, and the need for much longer term research as we move hopefully from a sort of pandemic to an endemic type of situation. So I think that's going to be a challenge. We're trying to repurpose some of our cohort studies towards vaccine, post-marketing surveillance type studies as well. But yeah, I think the scientific side of it's been not too bad.
Well, and tomorrow I'm actually going to be at WHO in Geneva here, and if you would be willing to work with WHO and with others, I think they would be very pleased to have a meeting of epidemiologists in January virtually.
Yeah.
And I think that it would be a very good idea. And if you can commit to helping with that, I'll certainly help. And I think we can get others to help. Oliver Morgan, who you may know, is working. He has a small epidemiological group that advises him now, but we can expand that. And really, I think it's a great idea. And I'll bring it up tomorrow at WHO.
We've only relatively recently put together a sort of transmission group within the UK to understand sort of epidemiological evidence emerging on transmission and where it's occurring, and to do that on an international basis, I think could be very valuable to help target control more rationally.
Good. Okay. Well, will you be willing to help us with this as we move forward? Okay. I'll bring it up tomorrow and I'll come back to you. I have your email. I'll come back to you and we'll see if we can't really set up something that would be useful worldwide.
Great.
Thanks. Thanks for the idea. Yeah.
Thanks, Andrew. Good little surprise guest there. Thanks, Andrew. We are
an important guest.
A very important guest.
Well, I don't know about that. I was just hot off Sky News, being controversial. I don't know if it's that controversial anymore.
Sounds like a good collaboration that's going to come out of this. Cool. We are at 2:15, so David, I just wanted to ask you if there is one key thing that you would like people to take away from this discussion, or maybe something you've learned from this whole time. What would that be?
What I would like the people to take away is that it's our responsibility, each one of us, to stop transmission of this infection and to protect those who we know are vulnerable. And to do that, we have enough knowledge to do our own risk assessment to know where we've been in 10 days prior to being in contact with people who are at risk. And we should take that to heart. It's not fair to the elderly, to people who have comorbidities, or to our families not to do our own risk assessment. And if we feel we would cause a risk to them, we should in some way prevent that risk from occurring. We know that masks prevent transmission to others. We know that we can physically distance and stay away from others, and we can all practice good hygiene.
Great, very important message, particularly coming up to Christmas when we'll all get together. Thank you so much for spending this time with us today, David. It has been a pleasure to have you on our Q&A, and we hope to speak to you soon.
Thanks, and thanks, Anne.
Thank you. Take care. Have a good Christmas.
Thank you. You too.
Thanks,
Bye-bye.
Andrew.
Bye.
Bye.